So I have the honor and privilege of sharing our own experiences in Nigeria with the scale-up of the third 90. And this is the outline I will be going through. Recently, there was a national AIDS indicator survey, which was concluded in December 2018, and preliminary results have been released in Nigeria showing that the prevalence of HIV in Nigeria is now 1.4%, with an estimated burden of 1.9 million persons living with HIV. As a result, we have also seen that the distribution of the burden of this disease is majorly in the South-South and the North-Central in the country. And about 80% of this burden is actually distributed across 20 states. The cascade actually shows that the biggest problem we have is with the case finding with the first 90. But once people are diagnosed, we are able to place majority of them on treatment. So we have about 88% of them placed on treatment, while 83% of those are virally suppressed. Now, it is so important to us in Nigeria that we provide universal access to viral load monitoring for all our clients because of the increasing number of persons on treatment, because of the increasing concerns about HIV drug resistance. And as you see in the chart on the right, the number of individuals has significantly increased, approaching about 1 million in the country. And there is decreasing mortality. But a lot of the studies have begun to show that there is increasing incidence of HIV drug resistance, which we should pay attention to. And with viral load suppression, we have about 20 to 30% of individuals across the country who are not virally suppressed with the monitoring that we have initiated. That shows that we need to really be very strict with monitoring and with also ensuring that people are suppressed. This actually shows the evolution of ART monitoring policies in the country. And basically, viral load monitoring as a routine started in 2015. And then the guidelines were also revised in 2016 to include the treat all, that's test and treat. If we look through history, we discover that at the beginning, about 2013, viral load monitoring was not available routinely. We were doing targeted viral load monitoring in the country. So between 2013 and 2015, basically there was heavy reliance on CD4, and we only had about 5 PCR platforms within the country. But by 2016, there was concerted effort and additional support from PEPFAR that led to increased number of testing platforms in the country to about 26. And with that, there was increasing number of persons that were able to receive viral load testing. So from about 58,000 individuals in 2013, we rose up to about 1,120,000 individuals that were able to receive in FY18. So as the scale-up began, we started to notice the fact that there was a lot of inefficiencies in the system, and the turnaround time was very long. And so the different stakeholders in the country came together and pooled resources and started what is called the National Integrated Sample Referral Network. This happened in 2017, and as a result of that, that has actually significantly impacted on the coverage of viral load for our clients. And this is actually what is responsible for the significant jump that you see between 2017 and 2018. The map at the bottom right actually shows the distribution of the platforms, the PCR platforms, and these are all supported, majority of them are supported by PEPFAR, and a few supported by Global Fund and then Government of Nigeria. So in order to understand better and to fully implement this scale-up, we had to do a root cause analysis. And this root cause analysis basically covered pre-analytic, analytic, and post-analytic phases of the entire system. So we had to look at basically the health sector, the health facilities, looking at the clients, their level of understanding, their literacy. We had to look at the healthcare providers, their capacity to be able to actually set up efficient systems to offer the test and to take blood samples, to process them, to store them, to transfer them to where the PCR equipment are located. Since not every facility would have a PCR equipment, it meant that there had to be some storage in -80 freezers in some facilities in order to be able to transport them eventually to where they will be tested. So we had to look at also the efficiencies within the lab to make sure that there was regular, uninterrupted supply of reagents and consumables to reduce equipment downtime through efficient maintenance contracts, and to also reduce power outages, in some cases, basically supplying solar equipment or generators. We also had to look at issues around inadequate storage capacity within the lab, and then the basically shortage of human resource in the facilities, sometimes resulting in very short hours being provided for service delivery. So we had to do some advocacy and make sure that the management of health facilities increase the human resource in the laboratory so that they can run shifts and run 24-hour service in order to be able to meet up with the demand. In addition to that, we had to make sure that there was efficient use of the results whenever they were made available to the facilities. And the dispatch of all these results had to also be integrated within the National Integrated Referral Sample System to ensure that both delivery of samples as well as delivery of results are integrated. So having done that, we came up with a framework to basically coordinate all these activities at different levels, at the national level, at the state level, and at the facility level. Basically making sure that there was proper leadership and coordination across departments and across specialties. So these are all the basic interventions, but I think what is important is the fact that we emphasize capacity building, not just for the healthcare provider, but also for the client. We actually declared a code red across most of our facilities and made sure that there was a massive campaign to enlighten people about the usefulness of viral load. In addition to that, there was a massive effort to make sure that the electronic medical record was made available at each of these our facilities, and that the lab information management system was linked to the electronic medical record system. So we were able to, through a basic analysis of our data at different levels, particularly at the facility level and with each program, we found that there was varying coverage as a result of our intervention, but the biggest problem is that coverage for children and adolescents appeared to be low. In addition, suppression also has improved over time, but viral load suppression for children and adolescents was also a challenge. So you see this graph that it shows that viral load suppression for adults could be as high as 76%, but when you go down to adolescents and children, you see it in the range of 40 to 50%. So this became a challenge that we needed to address. So some of the interventions that have truly worked are things like the National Integrated Sample Referral Network, and as a result of continuous quality improvement within the system, it has shown significant improvement in the coverage of viral load. And in addition to that, the number of samples that get rejected also reduced from 36% to 0.3%. Other promising innovations include the establishment of mega labs with high throughput equipment. In addition, we have also recently rolled out the DBS for viral load. Within the health facility, we had to ensure that there was a reorganization of patient flow and efficient use of time and appointment scheduling to ensure that there were no missed opportunities. Within that scheme, we made sure that there was color coding of patient folders in advance, And we also had what we call viral load ticketing, where a list of the services that an individual needs to receive was listed on a ticket. And basically, this was to reduce all missed opportunities within the health facility. In addition to that, I had mentioned the fact that we have EMR supported in all facilities. And as a result, we now have the National Data Repository, which is in a central location. And from any location, you can actually access data and do granular analysis of what is going on at different levels. Of course, continuous capacity building and refresher is ongoing, and there were distribution of job aids to make sure that people understood the algorithm and know what to do when the viral load result is out. Basically, in all our facilities, we try to establish what we call the drug and therapeutic committees, or the switch committees, who are able to take decisions very promptly and monitor clients over time to make sure they are virally suppressed. As a result of that, we have actually recorded significant improvement in the switch rate to second line, and recently we've started to also record switch to third line drugs. So in addition, basically based on the recent experience we have had of scale up, we started from a very low level of coverage from about 4% to about 58%, and we are still going up. We realize that the innovations are good, and that when they are brought to scale with fidelity, that we're able to actually, we are very hopeful that we'll be able to reach the third 90. However, we feel that it is important that we continue to promote health education amongst the clients as well as amongst healthcare providers to ensure that there is aggressive and active management of this entire system and continuum. In addition to that, paying attention to subpopulations like children and adolescents. We have discovered that most of the children and adolescents that are not virally suppressed, it is either as a result of wrong regimens or suboptimal doses or non-adherence. So we have tried to put systems in place to address all of that. There is also, of course, constant use of data for decision making, the fact that we are constantly looking at the data and taking decisions and addressing gaps as they come along. I would like to thank all those that contributed slides to this, the PEPFAR program in the country, University of Maryland, IHVN, the NACA, Federal Ministry of Health, and everyone else. Thank you.